And this is typical of dystonia. So dystonia is obvious in certain tasks and not others, in spite of use of the same muscles. So lower limbs when walking forward, not backwards, or not when you're dancing. Laryngeal dystonia. So when you're speaking, but not while singing or whispering. Writer's cramp, writing, but not using a screwdriver. So if you're knitting or buttering your clothes, you will be fine. As soon as you try to write, your hand goes into dystonia. Cranial muscles, grimacing when speaking. So you keep on doing this, but not when eating. So these are basically learned movements are the ones which are more prone to dystonia rather than movements which are infrequently made. Now let's look at another thing which happens in dystonia. Now, this 12-year-old girl has a generalized dystonia, a lot of gait issues, a lot of neck, and she keeps rubbing her eyes. See, again, I'll show you. She's having a lot of dystonic movements, and then she rubs her eyes, and her dystonia becomes less for some time. And again, it increases when I make her do things. Now, this girl is a boy, rather, is very badly disabled. His eyes remain closed all the time, even though he's fully awake because of the dystonia. So he puts his hand on his chin and his eyes open. So the way to open his eyes is to put your hand on your chin, and the girl has to rub her eyes to make the dystonic movements less. These are called sensory tricks. So they used to reduce dystonia, more of course in inherited dystonia than in acquired. Now the different types of dystonia. So this acute dystonia, this is an autistic girl who was given risperidone. Most of you see this all the time in your clinics. And the diagnosis, of course, is acute dystonic reactions, oculogyric crisis, of course. And that is basically oculogyric crisis is a type of ocular dystonia and happens typically with dopamine receptor blocking drugs or dopamine deficiency of any cause. So you may have a patient who has a dopamine deficiency because of inherited reasons. They also have oculogyric crisis. But in general practice, usually you see this in drugs like haloperidol, risperidone, rarely. The antipsychotics are much more common. Therefore, these should not be used very much. These are, of course, used much more, sometimes in metoclopramide. And the treatment, unfortunately, though everything is available, it should be parenteral. And the only we have is benzodiazepines and promethazine available in parenteral form. Otherwise, benztropine, diphenhydramine, if you have IM, it's much better. What about acute encephalitis? So this patient has a acute febrile encephalopathy, lost all the milestones, has a big head, and has a lot of dystonia with other movement disorders. You can see there's not only dystonia, there's a lot of other dyskinetic movements as well. The twisting movements of the legs, there's chorea, and all those things. And this, of course, the differential diagnosis is wide. You can have a metabolic disorder like butyric aciduria, which is the condition which this boy has, or other organic acidurias, or you could have other infections, like, for example, infections like Japanese encephalitis. Everybody should know about acute necrotizing encephalopathy in infants, where there's a lot of dystonia following the encephalitis. And then you have acute NMDAR encephalitis, which we'll talk about a little later. So all these things can give similar kind of pictures, but obviously the background, the family history, etc., the consanguinity will help you decide whether this is a metabolic problem or an infectious autoimmune problem. This is a girl who came to us, subacute onset of gait disorder, so acute subacute dystonia and other movements.
Day to you.
And all these dyskinetic movements, a lot of grimacing, a lot of intermittent movements, and continuous chorea dystonia. And actually had anti-NMDR positive in the CSF. So anti-NMDR usually comes with unconsciousness, unresponsiveness, but this girl otherwise is fine, but has dystonia without an encephalopathy. So that's another method, another way of presentation of NMDARE. What about chronic dystonia? This is, of course, a much wider topic. I'll just give you a glimpse of what you can see. Of course, one is cerebral palsy. This is a boy who has dystonic cerebral palsy. And there's a lot of hypotonia underneath. So there's dystonia, which is obvious to everybody. But there's also, when you remove the dystonia, basically everything is hypotonia. When he's trying to reach for the pen, his dystonia gets worse. You can see the number of overflow movements. There he's trying and his neck is moving when he's moving his hand. Then they sometimes have a lot of neonatal reflexes. So this boy, whenever you try to put him down, he starts walking like this. A walking reflex, which is seen in newborns and young infants, they are still present in this boy, and that interferes with actual coordinated walking. This girl has not only dystonia, but also chorea. So nowadays, when you see dystonia, you can see athetosis, chorea, along with that. So what's called dystonia plus, and that's seen very commonly in all types of cerebral palsies, not just one. So you have to identify the predominant one and treat that one, because that's the most important way of controlling it. This is another girl who came to us with a diagnosis of cerebral palsy, left-sided, from very early life. She's got this dystonia, she's got slow movements. There's no obvious pyramidal dysfunction. It's just a dystonic kind of Parkinsonian gait only on the left side. And we gave her a medication in the clinic. Most of you know what we've given her, but for those who don't, we gave her dopa, L-levodopa. The next week when she came, hand improved. Unfortunately, the video was not taken when the child was walking, but the walk also improved. Now, what you can also see is that a lot of this kind of these dyskinetic movements are because of this patient has been deprived of dopa for many years. And when she was given the dopa, her hand started having an excessive response to dopa, so excessive movements. So from less movements to excessive movements. That's dopa causing dystonia, dyskinesia. So dopa to very little dopa you have to start off with, otherwise you get these kind of movements, excessive movements. So when do you suspect this dopa responsive dystonias in cerebral palsy? That's the most common kind of one of the things you see. So undiagnosed movement disorders with normal MRI. So we don't know what's causing the dystonia, and the MRI is normal. It is given a label of cerebral palsy because it's early onset. But the MRI is not showing any lesion, any reason why she's having this problem or he is having this problem. Same thing, hypotonic spastic dystonic CP, no normal MRI. Relatively spared IQ. So the motor delay is excessive. The language, not language, but the social delay is not much. Oculogyric crisis, like I told you, that's a sign of dopamine deficiency. And if there are other movement disorders, especially Parkinsonism, then you may have high phenylalanine levels. I don't want to go into details of this. But when you have this kind of CP where you don't know what's causing the CP, just try dopa, like we tried in this case. And this is, of course, another place where dopa might work. This is a patient who had come to us who had an encephalitic illness and then had an MRI lesion in the right basal ganglia. And you can see that the left hand is causing was diagnosed as hemiparesis. And the same visit, we gave him dopa, and look at this. Fellow is fine. Hand is fine. He's walking also fine. So on the right side, you see how beautifully he's improved. So whenever you see a patient after an encephalitic illness, always try dopa. Now this patient has Wilson's disease, all the features of Wilson's disease. And this is the patient. Was otherwise not too bad, but she was given penicillamine and she worsened dramatically. And again, this is a condition where you get mixed movement disorders. So you get dystonia, you get tics, you get chorea, you get all sorts of things all together. And you have to identify what is the most prominent before you start any symptomatic treatment. In this patient,
तुला इंजेक्शन कुठलं चालू आहे गोळ्या कुठल्या चालू आहेत बेना काय हा
Very laryngeal
हा,
dystonia is
दुसरी
so
कुठली
obvious in this patient.
झिंकोनिया आणि
She's so smart, she can
हा
answer exactly what she's on.
बेनाल्जिस वय
Okay.
झिंकोनिया किती टाइम खाती
Anyway, then this patient, when the penicillin has been started, we gave her thiamine because she was on thiamine before and it had been stopped. And there was dramatic recovery.
तो असं
In Wilson's
बोटांवर चालून
disease,
दाखव.
nowadays we are giving all medications along with thiamine. So that seems to
जा
reduce
मागे
the
परत जा.
incidence of penicillamine. You know, penicillamine, very often penicillamine and all these things can induce excessive movement disorder
Yes, sir.
because it removes
नॉर्मल झालं ते.
all the copper, free copper, from immobilizes the free copper from the tissues, which then goes into the brain and causes more problems. And thiamine seems to help. This was out of Mahesh's case, which I was involved in. So looking at Wilson, because that's an important one. What are the presenting features? In children, most common I've seen is dysarthria and dystonia. In adults, tremors, Parkinsonism, and other conditions like abnormal gait and all that. Rarely seizures, rarely behavior or cognitive, and of course hepatic and musculoskeletal. But the neurologic Wilson's or neuro Wilson, as it is called, basically whenever you have somebody who's a school-age kid with dysarthria, drooling, dystonia, you know, please think of it because this is the treatable and most important disorder we have to treat. Another condition very important is pantheonic kinase degeneration. So this is patients present certain ethnic groups. I'll just show you their ethnic groups. And they have, initially they look like cerebral palsy because they are late walkers. They have this, you know, very slow, laborious walk. The foot is dystonic. You can see the foot is inwardly moving. And as time goes by, things get worse. And they go into the wheelchair. They have problems in chewing, movements, etc. So they typically have night blindness, early lower limb, stepwise deterioration, dystonic forms. And most of them are basically non-ambulant by 15 years and dead by 20. So it's really a bad disease. And unfortunately, you know, it's something you see these normal looking kids who go down in front of your eyes. And they all have these faces. These are different families, you know, impassive face, this vacuous kind of smile. And these are different. This is a brother, sister, and this is the third baby. So all have this slightly wide eyes and very typical faces, which they help you see this condition. We did a study on Indian patients, and we found that Indian Agarwal patients have a founder mutation. So if you see a movement disorder in an Agarwal patient, most likely you're dealing with this unfortunate diagnosis. Now, how do you treat dystonia? So oral drugs, levodopa has to be tried, I think, at some point in every dystonia, but will be much more helpful in certain dystonias like dopa responsive dystonia. Then the next drug, which I found very useful because it cuts off the action triggered dystonia, is gabapentin. And this has not been popularized much. For some reason, I don't know, still not as popular as it should be. So we use, 10 milligram per kilo, go up to 30, wait for some time, it doesn't get improved, go up to 60. And you always try one medication at a time because otherwise you get confused. Third is trihexyphenidyl, which is your Bexol or, Bexol, which is, or Pacitane, which is really, we found improvements only with very high dose. So small doses, giving quarter, half, 3 times a day is not going to do anything. You have to use 6 to 8 to 12 to 15 to 18 milligrams, which is a huge dose in these patients. And then other things like intrathecal baclofen, deep brain stimulation, etc., is of course things which are now available and should be used if the patient can afford. Other drugs, benzodiazepines are good. Clonidine is a new drug which seems to help. But generally, our experience is mainly the ones which are in the red or blue colors in this. So this is a patient with gabapentin. You can see she's has cerebral palsy. She has a fisting over here. She's got neck retraction. When she tries to reach for it, she's not able to get it. 3 months after gabapentin, she's sitting alone. Now the action doesn't cause as much dystonia as it should, as it was doing. And she's really improved dramatically. Of course, this is the best case where we always show our best cases, but this is the cases which will really tell you that gabapentin is something which we should use very early. And so let's go to the next big group.
Sir, we cannot see the slides.
Now you can't see?
Sir, we can see that weekend slide. No? After that, have you changed the slide?
Slides have frozen.
Oh my God. Sorry.
We can see one slide in which.
Can you see this? Can you see this?
No, sir. You have to stop share and again share. I think then it will work.
It says resume share. Oh.
Now we can see the
Okay.
share, please.
No, we cannot see the slides. It seemed like
Now.
Now we can see symptomatic treatments for the dystonia.
Correct. That's the one. So I just told you about levodopa,
Okay, thank you.
gabapentin, trihexyphenidyl, and the new things, of course, are deep brain stimulation. New things means this is going on for about 20 years now, intrathecal baclofen. And the new thing is clonidine, which is also, we are finding very useful in dystonic storms. So when you have very severe dystonia, clonidine would be very useful and very high doses. And you can see this? Can you see this?
Yes, we can. And it's yes,
so you
we
can
can.
see that the child is not holding her head properly. She's got cerebral palsy. And whenever she is doing anything, there are overflow movements. And 3 months after gabapentin,
She turns around.
now she's much better. She's more stable. She sits alone. So gabapentin, I think, is a wonder drug as far as dystonia is concerned. Compared to all the others, it has the maximum. And you can, minimum dose is 30 per kilo, go up to 60 per kilo. And sometimes I've even gone up to 90 per kilo. And main side effects are, of course, sleepiness, and sometimes they get ataxia and myoclonus, but something you should use in patients, because this patient has really improved dramatically. Let's go to the next one, chorea and Ballism. So definitions of chorea: involuntary, continual, irregular hyperkinetic disorders in which movements fragment with variable rate and direction, occur unpredictably and randomly, all very complicated. So I'll show you how do we diagnose. So basically, they are irregular. Let me just go to the next and I'll show you exactly how to diagnose. Ballism, however, are flinging movements. They also are continual, more or less continual, irregular, but they are more proximal. And they are part of the same spectrum. So let's look at this. 1 minute. Okay. So they are continuous, they are very fast, they are not suppressible, not stereotyped, not rhythmic, not distractible, not action triggered. So really they're continuous and fast, and they're quasi-purposive. So quasi-purposive is as if they try to hide the movement doing a purposeful movement, but actually, they might do this when the hand goes up. Or it's flowing kind of, there's a continuity about it, impersistent and jerky. So there are lots of things. Now let's see some examples. Tell me please if you can't see. This is a child who at last few months has a problem of excessive movements. And oh, it's not God, it's not moving. She started moving. So she's got these jerky movements, which you see, which are very fast. They're more on the right side. And she's having these kind of, flowing kind of movements, like almost athetoid at times. Sometimes affecting the right. We always look at the legs too. Often this one's not showing much. And this, of course, is the jack-in-the-box tongue. Keeps going in and out. And everybody has seen rheumatic chorea many times over. And this is Ballism, hemibellism, which is more on the, again, more on the right side, much more proximal, much more flinging, and TBM, tuberculous meningitis. Of course, there are different areas of the brain which are cause these movements, but they are similar in looks. That's why they're classified together. Chorea is more distal, lower amplitude, but Ballism is more proximal and more violent. Look at this boy. Came to us with this. I'll put this sound over here. Please listen to his voice as well. He was diagnosed as rheumatic chorea and responded to still a lot of chorea, which you can see very clearly. A lot of chorea. And ASA was negative, heart was normal. But that speech was different. A different kind of language. Speech was different, slow and scanning. Anyway, he was given steroids. And he actually improved a lot. And then everybody forgot about it. And 4 months later, he came with this.
Good.
He's become completely ataxic. And he has speech difficulty, again has come back. And the diagnosis is not rheumatic chorea, but anti-NMDAR. So I've shown you 2 cases of anti-NMDAR where they come with movement disorder without the usual encephalopathy or psychiatric changes or seizures. And so these are, fragmentary manifestations, but are being described more and more. And we've actually published a couple of them as, formfus kind of NMDARs. Now, how do you come to treatment? So whenever you see a chorea, the 2 most important are these 2. Then there are some rare causes like drug-induced is not rare. I've not shown you a video of that, but when you give dopa, you can, in some patients, you can, I'll show you an example later. So those are the 3 important causes. And there are rare causes like Wilson's, like post-pump chorea, but all those are very rare. I won't bother to show you anything on that. Remember, the symptomatic treatment of rheumatic chorea typically is sodium valproate. How it helps exactly is not very clear, but it was first described from India. And a lot of other anticonvulsants, carbamazepine also can help. We don't use haloperidol or pimozide initially. We use it very late. So we use tetrabenazine, which is the same thing which you have Tics stop or whatever, Revocon, which is very useful for even chorea and tics and all that. So valproate first, tetrabenazine next. And if nothing is helping, then you go to haloperidol. Otherwise, haloperidol you try to avoid in pediatrics. And specific therapy, of course, immunotherapy in rheumatic chorea. In even Aplar syndrome, you can get chorea. And revascularization in moya-moya is another condition where you get unilateral chorea. So you might want to use a specific treatment for that. Coming to paroxysmal movement disorders, this is a boy who used to get sudden episodes thought to be epilepsy, and sudden episodes which look like this. He starts walking funny. He has a lot of dyskinetic movements, which chorea, dystonia, mixed kind of movement disorders. And then it stops. And this is paroxysmal kinesiogenic dyskinesia, so PKD, when you trigger when the child starts moving, lasts for a few minutes, fully aware, and very often misdiagnosed as seizures. But they can have seizures as well. So that's sometimes can be confusing. And the test is diagnosis. They just give a low dose of carbamazepine, they are fine. And it's a genetic disorder, you know. Let's look at another paroxysmal movement disorder. This girl used to get up in the morning and have these kind of dyskinetic movements. See her mouth, she's having facial chorea. She's having, you know, and she used to also appear to be ataxic. When she went to put on the TV, you can see. So all this movement disorder with ataxia, but only usually more in the morning time, not all the time. And she actually had a low glucose in the CSF. So this child had actually GLUT1 deficiency. So GLUT1 deficiency, as you all know, comes mainly with seizures in the infancy and intellectual deficit and microcephaly and all that. But it can also come with intermittent movement disorders, and that's why you must always look for it. Then you come to tics, which are involuntary, sudden, rapid, abrupt, repetitive, non-rhythmic, simple or complex movements or vocalizations. So let's just do that a chart again. So what are they not? They're not action triggered. They're not rhythmic. What are they? They're intermittent for sure. There are gaps between each tic. They're distractible. So if you start talking to them, it might become a little less. If you give them something to read, it might become a little less. They're suppressibles. You can make them suppress them voluntarily, though it might be a little difficult. And of course, the most important is stereotyped. So they look very similar every time. And there's always an urge, the special characteristics. If you ask them, they say, dukta hai, aankh mein kuch jalan hoti hai, and they start blinking. But that's the urge. And very often they are multifocal. So at one time, you may have different tics, not just one tic. So let's look at the typical one. I'm sure many of you have seen this, but just... So she's got these neck tics. Okay. Then I ask him to stop. And he stops. And I'm threatening him. He keeps absolutely still. All the tics have disappeared. All the tics have stopped. This is a very easy clinical test to diagnose it. Look at this guy. This boy was thought to have seizures. Look at his eyes. Look at his eyes. She used to have this intermittent left eye deviation.
हंसना मत, आँख भी हिला मत, आँख भी हिला मत, आँख भी हिला मत, आँख भी हिला मत, मेरे सामने ही देख, नहीं, मेरे सामने ही देख, हाथ को हिलाने का नहीं, तो कंट्रोल कर अपने आप पे.
He can do it. It's not perfectly. It's a little difficult for him, but he has to really concentrate to keep his eyes straight. So ocular tics. Now let's look at this one. This is looked at a respiratory problem. Came with stridor. Having this funny stridor, continuous breathing.
Put your hands forward. Not yet counted at least 20. Don't make any movement. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 20.
As soon as you stop counting, he goes into excessive tics. So vocal tics. So all these are different types of tics, can affect anywhere. So most tics are basically inherited. You don't really have MRI abnormalities in majority. You don't require to do many tests, and they're classified depending on whether they're transient, happen for some time or go away, or they remain for a longer time, like Tourette syndrome. And you may have associated attention problems obsessive compulsive. You very often have family history of tics, and many times the parents don't even know they have tics. Many times the mother doesn't know she has OCD. I've always noticed the OCD part in the mom. That is the kind of thing which you see. And there's one condition you should know about, which has been very controversial. It's called the condition called PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. So you get a febrile illness, it's abrupt onset, there's a lot of behavior changes, obsessive compulsive behavior, anxiety, aggression. They lose appetite, they start having tics and stereotypies. I'll tell you about stereotypies just a little later. They have sleep problems, they can't sleep. Sometimes they have enuresis, sometimes nocturnal, sometimes even diurnal. And there are new onset learning issues, fine motor difficulties. And these are associated with any infection. Strep, of course, when it was associated, it was called PANDAS. But PANS is better because it can be associated with other infections as well. And sometimes response to immunotherapy. But there's a lot of controversy whether it really exists, but I think it does. And I always look for it when there's an acute onset of tics. So what is the general treatment of tics? Nothing. You don't need to do anything unless the kid is bothered by it. Parents are a little obsessive, so they keep on saying, thoda movement hua, ye wo hua. It doesn't really, you don't have to treat that. And if you have to treat, you try behavioral approaches. This is HRT, which is habit something therapy. I forget now what the R stands for. And you use, this is done by, in Hinduja, we do it with a lady called Somini Mehta, who does it. And drugs which I use initially are clonidine, most safe, and then you can use risperidone or tetrabenazine. So these three are the drugs we usually use, and rarely other things are required. But this is, this is symptomatic relief. You stop, they again come back. The last thing is motor. I think last two is motor stereotypy. I'll just go fast. I'm getting over now the time. So these are involuntary pattern, coordinated, repetitive, non-reflexive movements that occur in the same fashion with each repetition. So let's look at this. They're not action trigger. They're not rhythmic. They're suppressible, distractible, intermittent, stereotyped. So they look very much like tics, but they're usually one pattern. And sometimes they, to make things more confusing, they occur with tics. So let's look at this. For example, autism, you get Rett syndrome. They're doing the same thing again and again. Over Rett syndrome, is they use hand stereotypies, they put them in the mouth, they make these funny movements. This kid has got autism with Down syndrome and does the same thing again and again. This kid has got autism again, and he keeps moving the head like this. So it's just basically a way to reduce anxiety. Remember, it can occur in normal kids as well. So just because you have a stereotypy, and though it's much more common in blind children, in children who are autistic and retarded, intellectually disabled, very often it is not something which you don't see in normal. Sometimes normal kids also have it. It's a kind of anxiety reducing mechanism. Unfortunately, this video was not working when I checked it last. But this also can occur. This is a child who had anti-NMDA encephalitis. And in that, she was getting these kind of, I'll just show you what she was getting because it's not playing. She was getting these continuous, repetitive, like seizure-like movements. And no, it's not moving. And actually, it was a stereotype like this. You can see how it's just like a seizure, like a repetitive seizure. And though she appears awake, she's actually completely unaware of what's happening around her. She doesn't respond. So she's proven case of anti-NMDAR who responded to treatment. Myoclonus, positive myoclonus, negative myoclonus. That means positive is your movement is there, and negative when the movement is interrupted and you get an atonic kind of thing. And it can arise from any part of the neuraxis. Positive myoclonus, basically, it can be epileptic or non-epileptic, and negative is almost always epileptic. Most important thing is very fast, very jerky. These are the two things. And this is a patient who has a newborn epileptic encephalopathy with myoclonus, multifocal positive myoclonus, and this kid is a negative myoclonus. She's standing and she loses balance because there's a loss of tone. And therefore they present like ataxia, something of that sort. Almost always, they can also be non-epileptic. For example, asterixis. When you ask the hepatic failure patient to put their hands like this, that's a negative myoclonus, and that's non-epileptic. And this is another very important non-epileptic myoclonus in childhood, the obsoclonus myoclonus ataxia syndrome. You can see the eyes are chaotic in direction, conjugate deviation, either in the horizontal, vertical, all gazes. There's a lot of myoclonic jerky movements. And there's a neuroblastoma, which of course, after treatment, patient improves a lot with immunotherapy and surgery. And this patient is a periodic myoclonus SSP. So he's having it intermittently only on the left side. And this kid also was thought to have SSP. But she also has, on the left hand, you can see slight myoclonic jerks, which are periodic. So whenever you have a periodic myoclonus, you always think of SSPE. But then she had TB actually, tuberculoma in the subcortical region. And this tells you that this kind of periodic myoclonus comes from that area, even in SSP and even in this patient who had a lesion over there. So it's just, a myoclonus which comes from the thalamic and insular areas. Tremor, not suppressible, not distractible, not stereotyped. Action sometimes triggered, but sometimes can occur in rest also. Most important, rhythmic. So that's important. And of course, distal is always more than proximal. Tremor types, I won't go into details, but resting tremor usually typically in Parkinson's. Hand is completely at rest and you get this kind of pill rolling movement. Action is mainly in postures. You make them do this, and intentions. So kinetic also with voluntary movement. So dystonic tremor is something which is many people are not aware of. It's basically you have tremor as part of a dystonia. I'll show you an example. So this is the typical action tremor. This child, this teenager had this movements. Her grandmother had the same thing. So essential tremor. This child is a young infant. I don't know if it's going to work or not. It doesn't seem like it's going to work. Oh God. You can see the tongue tremor. This is a patient with had diarrhea and then developed this tongue tremor, and this hand tremor has pigmentation. Everybody knows this is infantile tremor syndrome or anemia tremor pigmentation syndrome, or basically B12 deficiency. And so essential tremor, you give beta blockers, very typically helps. And of course, infantile tremor, you need B12, and very often after you give the B12, the tremor actually increases. But now all this has become pretty uncommon. This is the dystonic tremor I was telling you about. Make the hand movement like this, and she has this kind of wing beating kind of tremor. This looks like a tremor. If you look at the hand, it's a little dystonic. So we gave her trihexyphenidyl, and the tremor almost disappeared. So this was actually caused by a post-hypoxic. So dystonia may look like tremor, and tremor may actually overshadow dystonia. So you have to treat like dystonia. I think I'll stop here because I think this is, I overshot my time. What do you think I should do?
Sir, how many slides more are there?
I've got about 4 or 5 slides.
And you can complete, sir.
Okay, so
we have got 5 minutes.
So Parkinsonism is a rare movement disorder, and these are the 4 cardinal features. Bradykinesia, slowness of movement, very seen in childhood as well as adults. Rest tremor, almost never seen in childhood, but can be seen, more seen in adults. Rigidity, less seen in childhood. Loss of postural reflexes, seen in both. Often in childhood, it coexists with dystonia. And the younger you are, the dystonia predominates later on the Parkinson's. And this is Wilson's, dopa responsive dystonia, I've already shown you, and Parkinson's. And all these are basically autoimmune encephalitis conditions which can happen. So this is Wilson's disease, very Parkinson, impassive face, hardly movements, any movements, and some tremor movement was there, some dystonic movements with the left hand. And after we gave her, she was not responding to any treatment. And after deep brain stimulation, she really doing well. This is a Wilson's case, but this symptomatic treatment sometimes help. This is a 9-year-old girl who had a thoracic syrinx and was sent to me for opinion of surgery because she had this gait problem. If you see her, she's very bradykinetic, and the way she turns, en bloc turning, so she takes a long time to turn, and then she turns again. Hands automatic movements have stopped. And then the glabellar tap is positive. So all signs of Parkinson's. And then we give her dopa. 1 month later, she's much, much better. So dopa responsive dystonia can come with dystonia and Parkinson's. And this is an older child. So the younger children come with dystonia. The older kids come with Parkinson's. So remember, always try it. And this is I was showing you the side effects of dopa. So this is a child who had post-encephalitic dopa Parkinsonism. Absolutely hardly does anything, impassive face. The Japanese encephalitis.
पकड़ो पीछे से आप उसके हाथ में बोल दो
And then she was given dopa. She's got excessive movement. So there she could not even reach out. Over here she's reaching out, but she's moving a lot. So it's a little difficult. It's like a very fine line before you get perfect control. So I think we'll leave this. This is the patient with basic ganglia encephalitis. Again, had come with Parkinson's. Hardly moves. No postural reflexes. Keeps falling. And with IVIG.
तेरा नाम क्या?
Essentially, lots of conditions, and the last thing is benign transient movement disorders occur mainly in infancy. Everybody knows about Sandifer Syndrome, which is a kind of reflux and hernia, hiatus hernia with dystonia looking, shuddering attacks. I'm not going to show you all this. I'll show you one unusual one. The eyes, they go up. We did very short one. You see this? This is the kind of benign paroxysmal tonic up gaze. There it goes. And then it comes down again. It's absolutely benign, it's transient, and it goes away. And sometimes you give L-dopa in response. Sometimes you may have to give it. So the etiology of movement disorders depend on the correct identification. That's the most important. Always try levodopa in dystonia, undiagnosed dystonia. Rule out Wilson's in all school kids and teens with any type of movement disorder. And treatment, though symptomatic, is sometimes quite dramatic in its effect. So I think I'll stop here. I'm sorry I overshot the time, but it's a huge topic, and that's why it took a little time.
No, sir, you have completed on time only. In fact, 3 minutes are spare. So if anybody has questions, you can directly ask to sir. It's our privilege that you are we got you on board and you delivered such a nice lecture. It's a last topic, and you have covered within 1 hour all the possible etiologies. It was simply understandable. So that was good. So I would request any pediatrician or GPs who have any questions or query, it can be silly one, but you can ask to sir. We have got some 5 minutes.
Can I ask a question?
Yes.
Yeah.
Sir, if
Please
a
go ahead.
4 to 5 year old child with suspected decreased hearing, so what do you prefer, audiogram or Pda? 4 to 5 year child.
If it is not part of movement disorder, maybe you can directly send me. You can take my number from here and we can discuss it straight. I think the short answer is I prefer Pda if he's not cooperative. Okay.
Thank you, sir.
Okay. Any more questions?
Okay, I think.
And sir,
yes.
Yeah, there are. I have one short question for you. In this kind of movement disorder, all the patient requires MRI, or there are some set of conditions that you should tell GPs or pediatrician to get MRI, something like that.
Yeah. So if suppose the patient has perinatal hypoxia, asphyxia, or chronic, something of that sort, especially if you're sure over the etiology, you don't really require a MRI to tell you what it shows. So asking in these generally hypoxic ischemic encephalopathies, CP, cerebral palsies following that, or in severe jaundice where there was exchange transfusions done and 40, 50 bilirubin, don't try and there's no point in wasting their money. Whatever you see is not going to help in the management. Otherwise, if they're not sure of what the etiology is, always get an MRI. You don't require MRIs in tics. You don't require MRIs in most of the times in stereotypies. You don't require MRIs in mostly in tremors. You require MRIs basically in dystonia, maybe occasionally in chorea, and I think of course in myoclonus you usually require MRIs. So basically the dystonia is the main group of conditions where you don't have a diagnosis, definitely go for an MRI. Okay.
Thank you, sir. Thank you once again for your time.
One more question. Can I?
Okay, this will be last question. Yeah.
Sir, in SSP, nowadays we are giving measles to each and every child. So still, do you get SSP?
Well, yes. Unfortunately, the answer to that is yes. The measles vaccine is being given. The reasons are multiple. One is, of course, you may get after measles vaccine, you may still get measles with maybe a subclinical attack, or you may have had a subclinical attack before you given the vaccine. Very often, the 9-month vaccine is given, and you may have earlier measles. We've given all our mothers vaccinations. Many of mothers are vaccinated. As they grow older, their immunity wanes, and they are prone to measles as well. So that is the reason why it doesn't go away from this thing. So I think this MR program, which has been started 2-3 years ago, I think that should make a difference. And unfortunately, this pandemic may have brought on a lot of SSP because many kids have missed their measles vaccine. Okay.
All right, so that concludes the time for Dr. Vrajesh Udani. If any have more queries, you can put in chat box. We can forward to sir and then get back the answer. So after finishing first lecture, now I would like to invite my friend and colleague, Dr. Saurabh, who is another moderator for the second session. So he will carry forward and he will invite the next speaker. Dr. Saurabh, are you around?
Yeah, thank you, Hiren. I'll invite our next speaker, Dr. Supratim Sen. So our next speaker for today's meeting is Dr. Supratim Sen. He is a senior consultant pediatric cardiologist with SRCC Hospital with over 13 years of experience in the field. He has done his F&B in pediatric cardiology, and following which he did his further fellowship in pediatric cardiology from Sydney Children's Hospital. And he has been working with SRCC Hospital pretty much since the inception in 2017. I will therefore welcome Dr. Sen and looking forward to hearing from him. Thank you so much.
Thank you, Saurabh. Can you all hear me?
Yes, Supratim. Yeah, we can hear you.
Thank you for the kind introduction. So I'm going to speak on interventional procedures in pediatric cardiology, just to give you a gist of the work that we do. And as Saurabh mentioned, we are recently past our 5th year in this hospital, and we did our first intervention in May of 2017. Just a little bit about myself. So I'm an associate editor for our National Pediatric Cardiology Journal, and I'm a reviewer in a number of international journals also. So I'll tell you a little bit about interventions. In the present era, a lot of structural heart interventions can be done in the cath lab by minimally invasive techniques. And these procedures are as effective as surgery with faster recovery in these specific situations. So whenever possible, we do prefer doing the case in the cath lab if the congenital heart defect allows us to. So I'll just take you through a few cases. Some of them are standard, some of them are a little rarer and more interesting. So this is quite a common case which a lot of you might have come across. This is a child who presented to our emergency department on day 10 of life, was initially delivered at another hospital and discharged on day 4. It was a normal delivery, and came back on day 10 to our ER with refusal to feed and respiratory distress. And on examination, the baby was sick looking. You can see there was tachycardia, tachypnea. Remarkably here, the femorals were not palpable, and that obviously then gives us a clue to the diagnosis. The child had normal heart sounds with a soft ejection murmur, and the venous blood gas done in the ER showed severe metabolic acidosis. So any clues to what this is? So this obviously is a coarctation of aorta, which we know because the femorals were not palpable. And the child also had metabolic acidosis, which is secondary to the left ventricular dysfunction. So coarctation of aorta is a narrowing of the arch of the aorta, which you can see here on this echo. So this is the transverse arch, and then in the upper descending aorta on the color flow, you can see there is a little bit of a turbulence there with narrowing. When we put a Doppler across this on echo, you see there is a diastolic tearing of flow, which isn't seen in a normal aortic flow. And the reason these children present later on, not immediately at birth, is because at birth, the PDA is open. So it's only once the PDA starts constricting, which happens after about 3 to 4 days of age, is when the lower body perfusion suffers, and then these children present with coarctation. Manifestations of coarctation. So this patient, because of the LV dysfunction, was taken for an emergency balloon dilation of the coarct. You can see the narrowing there, and then we do a balloon dilation. You can see the waist here, and the coarctation opens up, and then these children have a very dramatic recovery. This patient's left ventricular function improved in the next 24 hours. And within 3 days, we could reestablish feeds and discharge this baby. So they come in very sick, but if we pick it up in time, they have a very dramatic recovery. Important learning points from this particular case is that any acyanotic baby with an acute deterioration, it's not always sepsis. We should also think of duct-dependent lesions. And whenever a child has metabolic acidosis with high lactates, that's a sign of inadequate systemic circulation, and it could be a critical congenital heart defect. And it's always a good idea to palpate the femorals before discharging a baby from the nursery. We do routinely palpate femorals at birth, but as you saw in this case, if the PDA is wide open, you might not pick it up right at birth. So again, in another 3 to 4 days, if we palpate the femorals, we'll pick up a lot of the coarctations. The second case was an index case for us, and I'll tell you why. So this was a 14-day-old baby who presented to us in Jan of 2020. So this was pre-COVID lockdown times, and this child was born with a weight of 3.1 kilograms with a saturation of 60s. So the child was cyanosed, but wasn't in any distress. So had a quiet respiration. The heart sounds were apparently normal. And this child was born in interior Maharashtra, but the pediatrician did suspect a cyanotic heart disease and started this baby on prostaglandin and transferred to us. And on echo, we confirmed the diagnosis of VSD with pulmonary atresia, which is also known as TOF with pulmonary atresia. So in this condition, as you can see on this diagram, there is no forward flow across the pulmonary valve. So because of the VSD, this deoxygenated blood will then mix with the oxygenated left ventricular blood, going to the aorta, and then through the PDA, there is blood flow into the lungs. So the first step is to keep the duct open, which is done with prostaglandin. And then we do a palliative procedure, either a PDA stenting or a BT shunt, to keep this child stable for the next year or so of life. And at about 9 months to 1 year of age, we do the complete repair in these children, where this VSD will be closed and a tube or a conduit will be used to connect the right ventricle to the pulmonary artery. So this patient, along with any other patients who have pulmonary atresia, will need a palliation, an emergency palliation to be done in the neonatal period. So you can see here that all duct-dependent pulmonary circulations, whether you have a VST, whether it's an intact septum, whether there's a single ventricle or a tricuspid atresia, all of these patients are pulmonary atresias which will require a neonatal palliation. So this child had a hybrid PDA stenting with a carotid cut down. And what that means is that we do the procedure in the cath lab, but we do it in tandem with our surgeons who give us a carotid cut down. So here you can see that we have flipped the baby. This is known as the flip technique, where the head end of the baby is towards the foot end of the cath lab. And this is to get the length of the cath lab to do a procedure. The first step is the surgeons giving us the surgical cut down. So they will expose the carotid artery, and then we put in a short sheath. And through that sheath, then we start our procedure. So the first injection shows the arch of the aorta, and you can see that there is a vertical PDA, which is supplying the branch pulmonary arteries. So this is the schematic diagram. And the reason we use this carotid approach is that it looks straight down into the vertical PDA. So we will put in a stent into this PDA. So the first step is taking a wire through the PDA into the distal pulmonary artery. And over the wire, then we take in a coronary stent. So there are a lot of angiograms which need to be done to place this stent. We have to make sure that we cover both ends of the PDA. A few more check angiograms. And then we inflate the balloon and the stent is deployed. So you can see that the struts of the stent have opened up, and then we are deflating the balloon. And with the wire still in, here we have removed the balloon. You can see that the stent is inside and both the pulmonary arteries are filling well. And finally, we remove the wire. And this is our final angiogram, which shows there is good flow in the PDA stent into the pulmonary arteries. So this was the first time we used this special technique of the hybrid carotid cut down. And since then, we have done quite a few cases. I'll just share our data with you. But the post-op stay is pretty standardized for us now. So we ventilate these children overnight. We keep them on noradrenaline and adrenaline infusion. We give them heparin infusion for 48 hours so that no clots form in the stent. And then they are discharged home on dual antiplatelet therapy. They require about 3 days of ICU stay and about 10 to 12 days of hospital stay in total. So the advantage of the hybrid carotid stenting over our conventional PDA stenting approach, the earlier PDA stenting which we used to do was the femoral artery. But with the hybrid carotid technique, we have a much more straightforward procedure because of the way the carotid artery directly faces these vertical PDAs. So it's much easier to engage and cross the PDA and then to deploy the stent. And over the last 4 or 5 years or so, PDA stenting has gained a lot of prominence over the conventional neonatal palliation, which was the BT shunt. So these children with the stents are usually much more stable in their post-op course, and they have a quicker post-op recovery. So now coming to our experience at SRCC, since 2020, this has become a preferred institutional approach. We use this hybrid carotid technique for all vertical PDAs with pulmonary atresias. And we have done a total of 22 PDA stents in this period, out of which 19 were attempted with this hybrid carotid technique. One was unsuccessful, which went for a neonatal surgery, and that child is doing well. With the others, all of them were successful procedures. We had a median age at intervention of 24 days, and the mean weight of these babies was 3.2 kgs. The mean fluoroscopy time in the cath lab was 18 minutes, and the mean procedure time was about 1 hour. So these children are in hospital for about 11 days post-procedure, and our median follow-up duration was 3 months. But you can see here that some of the patients we did early in our cohort have now been followed up for over 2 years. There were no complications in the vascular access, so the carotid vessels were patent in all these patients on follow-up. And at the time of last follow-up, 6 patients had undergone their second stage corrective surgery, which is the VSD closure and the RV2PA conduit. And in fact, as we speak, 2 more patients are waiting to get admitted this week for their corrective surgeries. We had 1 early mortality in this cohort due to sepsis. This child had a Klebsiella sepsis and septic shock about 27 days post-procedure. And we had 1 late mortality, which was about 7 months after the procedure. And this was quite tragic. This was in the second COVID wave. This patient was supposed to come in for their second surgery, but contracted COVID-19 and then succumbed. And we published our early experience of the first 11 patients. This is from last year. This is in Cardiology in the Young. Now coming to another case, this is an older child, 7.5-year-old, and she presented to us in 2018 with a weight of 16 kilograms. And you can see here from her blood pressure readings that there is a difference between the upper limb and the lower limb blood pressure. She also had a loud second sound, an injection murmur, and a diastolic murmur on auscultation. And as you probably suspected from the blood pressure, she had a moderate long segment coarctation of aorta. But in addition to that, she also had a large patent ductus arteriosus, severe concentric left ventricular hypertrophy, and severe pulmonary hypertension. So PDAs, which are large, will at one stage Eisenmengerize, and the first thing we had to decide was whether this patient was operable or not. Luckily for us, the CAT data did show that she was operable. Now, as you know, PDAs nowadays, we do close routinely with device closures. But here, as you can see that because of the coarctation, if we were to just put a device in here, we would worsen the coarctation. So we discussed this case. Surgery was also not a straightforward option with this age and weight. So we discussed it. We did a CT scan to get a better idea of the anatomy. You can see that this is the long segment coarct. There is the PD over there. This is the pulmonary artery, and that's the aorta with the narrowing. So the best option here seemed to be putting in a covered stent, which would address both the coarctation, and the outer covering of the stent would then also occlude the PDA. But then the limiting factor became the arterial access, because for a covered stent, we needed to put in a 12 French sheath, and that would have been very dangerous in a 16-kilogram girl, because we would have damaged the femoral artery. So that's when the surgeon suggested to us that they can offer us a surgical cut down for a right common iliac artery access. And this is again a hybrid procedure now. So the surgeons have given us the access. This is in the right iliac fossa. This is the common iliac artery. And through that, we are then going to put in this 16 millimeter covered stent. So this is during the procedure. You can see that it's a very big sheath, but because of a large diameter of the vessel, this goes in pretty smoothly. And on the angiogram, you can see that this is the long segment of the coarctation. Now we have placed our stent and we start deploying the stent. So this is the AP and the lateral views. We are deploying the stent with a rapid right ventricular pacing so that the stent does not move while we are deploying it, and the position is perfect. And then once it's deployed, we are then doing check angiograms here to see that we have got good apposition to the outer walls of the aorta. And here you can see that the PDA is not fitting anymore. So the PDA is also completely occluded. And finally, we do this 3D rotational angiogram, which is similar to a CT scan. So we can do 180 degrees look around of the vessel just to see that there is no damage to the vessel after the stenting. So hybrid interventions help us to overcome the size limitations of our conventional transcutaneous access, and they're safer to maintain vascular patency in these slightly challenging cases. And also we can sometimes combine off-pump surgical procedures such as VSD closures with a hybrid intervention. So it can be done without putting the patient on a cardiopulmonary bypass, and then they have a quicker post-op recovery. The next case was of similar age and weight. So again, 7 years, 16 kilograms. And this child presented to me with unexplained desaturation. The child had a saturation of around 56%, normal heart sounds, and the initial echo was also reported as normal. The only thing slightly unusual was that the right pulmonary artery was dilated. So whenever we get this type of unexplained cyanosis, we also do a contrast echo where we will inject agitated saline contrast into one of the veins of the child. And this contrast echo came back positive. So whenever the contrast echo is positive, that is indicative that this patient has a pulmonary AV fistula. And the reason of that is that the right ventricular blood goes into the pulmonary arteries, and then there is a mechanical filtration which happens in the pulmonary capillary bed. So if you inject agitated saline in a normal heart, you will not have any air bubbles seen in the left heart because the capillary bed will just filter out all the air. But if you have a pulmonary AV fistula, as seen in this schematic diagram here, that bypasses this pulmonary capillary bed, and then the agitated saline is seen filling the left heart after about 3 to 4 weeks. So this patient had a clinical diagnosis of a pulmonary arteriovenous malformation. You can see that there is a shadow here, which is suggestive, but the echo confirmed the diagnosis. And then we did a CT pulmonary angiogram to get the exact anatomy. So you can see that the right pulmonary artery was dilated, and this is the pulmonary AV fistula, which is then coming back into the left atrium. So this patient was taken to the cath lab for closing this fistula. We are first doing some pulmonary arterial angiograms to define the fistula, and then we will pass a wire through the fistula into the left side of the heart, into the left atrium. Once the wire is into the left atrium, we actually passed it into the left ventricle, aorta, and then we made an arteriovenous loop and pulled it out of the other side. So this wire is going from the right femoral vein higher up into the RA, RV, PA, into the left atrium, left ventricle, aorta, and then out of the right femoral artery. The reason we made this loop is because we have to put a large sheet across this fistula, and having a loop means we can hold both ends of the wire and give extra support to the sheath. So this sheath is now going across the fistula right into the left atrium. And through this delivery sheath, we can then deploy a large device. So this is a special device with 3 discs. And we know from the CT that this is the location of the fistula. So we are slowly pulling back the discs of the device. And you can see that the device is now getting deployed across the pulmonary AV malformation here. So now we are doing check angiograms to see that the location of the device is good. We also have a transesophageal echo here to check on the echo how the location looks. And we do multiple angiograms in AP and lateral view. And once we were happy with the location, we are going to unscrew this cable and the device is released. And so the device remains there and the sheath and the cable come out. So that's what the angiogram looks like, or the X-ray looks like. You can see that there is now a device sitting in the pulmonary AV fistula. And with this, there is an immediate improvement in the SATs from the 50s right up to 96%. This patient required 1 night of PICU observation, and then we could discharge after 2 days. And now at about 4 years of follow-up, the child is doing well. So pulmonary AV malformations are very rare. They will have a normal cardiac examination, but X-rays might show a shadow which is suggestive of this. Echo contrast echo is the confirmatory test here, and the CT pulmonary angio will help us delineate the exact anatomy. Of late, we now also see there is an association with Abernathy malformations, which are portosystemic venous malformations. These are often associated with pulmonary AV fistula. Now I'll take you through some interesting double device cases, which means putting in 2 devices in the same patient during the same procedure. So the first case was a 5-year-old child weighing 12 kilograms who had an AST and a PDA. So you can see here, this is an aortogram showing there is a small PDA that is filling out the pulmonary artery. So we cross the PDAs from the pulmonary side into the aorta, and then we will put in our sheath across that, and then the device goes up into the sheath. And from the venous side, then we start deploying the device and pull it back into the PDA. So once we are happy with the location, you can see here that we are deploying the 3 discs of this device. We do a check angiogram to see that the device is in perfect location. And then we do unscrew this cable and release the device to approve the PDA. So that was the first part of the procedure. The second part is the ASD device closure. So we have put in a catheter on the wire from the right atrium across the AST into the left atrium to the left upper pulmonary vein. And over the wire, then we're taking a larger sheath for the delivery of the device. And now the ASD device is coming in. So this goes through the sheath. Then we slowly unsheath the device. So the left atrial disc comes out first. Then we pull it back across the AST and pull out and deploy the right atrial disc. And once we are happy that the device is in position, we will again do a transesophageal echo to confirm position, and then we unscrew the cable and release the device. So you can see here that at the end, there are 2 devices in this patient, the PDA device and the AST device. The next patient was a 4-year-old child weighing 10 kilograms who had a VST and a PDA. So here, the first angiogram is the LV angio to delineate the ventricular septal defect. You can see that the right ventricle is getting filled here, and the VST is over here. And this angiogram is showing the PDA. So it's an aortogram. The PDA is filling the pulmonary artery. So the first step is crossing this VST, which we are doing from the LV side. We have gone into the right ventricle and then into the pulmonary artery. And once our wire is into the distal left pulmonary artery here, we then take in a second catheter from the vein. We will again catch this wire from the arterial side and snare it out. Reason being the same, that we want to create an arteriovenous loop, as you saw in the previous pulmonary AV fistula. So here our wire is now going from the aorta into the LV, across the VST, RB, RA, out into the IVC and the right femoral vein. And through that right femoral vein, then we are passing this delivery sheath which is now going from the RA, RV into the LV into the ascending aorta. So once we are happy with the location of our delivery sheath, the wire and the catheter will come out, the other catheter come out. Through this delivery sheath, we are now putting in the VSD device. So the VSD device, the left ventricular disc is deployed first. We pull it back across the VSD and deploy the right ventricular disc. And then with the VSD device deployed, we will do LV angios again to see that there is occlusion of the VSD here. So in a simple VSD device case, this is where we would release this device. But here, because this child also has a PDA, we hold on to the VSD device. Now we are going to again cross the PDA from the pulmonary artery into the aorta, put in another sheath across the PDA into the descending aorta. Here's our PDA device coming in into the descending aorta. And then we deploy the PDA device, which is being done here. So this is on the aortic side of the PDA, and then this elongated portion of the device is into the pulmonary artery. So the first step is checking that the PDA device is in position. Second step is releasing the PDA device, coming out with that delivery system. And the third and final step is releasing the VSD device over here. And then we come out with the VSD delivery system. So by itself, both of these procedures are pretty standard, VSD and PDA device closure. But when we do it together, we have to be a bit careful. There's a lot of hardware in the heart of these patients at one time. And we have to do it in a sequential, systematic manner so that the devices remain in good position after their release. So those were the double devices. I'll show you a few still images of a percutaneous pulmonary valve implantation, and this has become quite standard now in our pediatric cardiac practice, especially in the West. It is still prohibitively expensive in India. The cost of this procedure comes to around 22 lakhs, and so a lot of patients are not able to afford this. But what this technology is basically there's a stent into which a valve is sewn on. So this is a bovine jugular vein. And this is then put across the narrowed or leaking pulmonary valve. And we then inflate the balloon, deploy the stent, and we then have a good competent valve which is placed without an open heart surgery. So this is generally done in post-petrology patients who, as you might know, often have a residual stenosis or regurgitation. And in their second or third decades of life, when this chronic stenosis or regurgitation is causing problems, we can then do a percutaneous pulmonary valve implantation. So transcatheter interventions have major advantages over open heart surgery. There are quicker procedures, there's less pain, the patients can be discharged faster, there's no surgical scar, and the patients are not exposed to the ill effects of cardiopulmonary bypass. However, there are limitations. Not all congenital heart defects can be treated with the transcatheter interventions. Surgical options might be the only option in many of the CHDs. There are age and weight restrictions. And as you saw, the delivery sheath size often limits as to how small a patient we can put in a device in. But if you compare an open heart surgery where the patient has this type of a morbidity with a VSD device closure in this child done just one day previously, you can see that whenever possible, we do prefer to do a transcatheter intervention over an open heart surgery. I'll just show you this last case, which wasn't really a transcatheter intervention, but it's interesting in how technology now helps us in the diagnosis. So this was a 9-year-old boy who presented to me in the first lockdown, and the child gave very classical history of episodic palpitations for the last 4 months. There was no history of loss of consciousness. The symptoms were not related to exertion. There was sudden onset and termination. So history was very suggestive of supraventricular tachycardia. However, the child had a normal ECG, normal echo and normal Holter. So we weren't able to capture this. At that point, I did notice that the father was wearing an Apple Watch, and ECG had just been introduced on the new models. So I told him that if you have these palpitations in your son, just make him put on the Apple Watch and check his ECG. And within about 2 weeks, he called me that he has captured an ECG with the palpitations. And you can see here that there's very classical SVT. So this patient has subsequently undergone an radiofrequency ablation and is doing well. So this was an interesting case where just routine mainstream technology helped us make a diagnosis. I'll go over a few general points of congenital heart disease treatment. The timing of treatment: large VSTs with severe pulmonary hypertension, we normally will treat them between 3 to 6 months of age. A moderate VSD with no PAH, no CCF, we can wait till after a year of age to treat them. ASDs are generally treated between 3 to 5 years of age. AV canal defects usually between 3 to 6 months of age. Tetralogy of Fallot, if the child is stable, we can wait for the 6 to 12 months of age to do a complete repair. But if required, we can do complete repairs earlier. As you saw in my first slide, we did a complete repair in a 1-month-old child after a failed PDA stenting. But even in small children, if we don't want to do a complete repair, we can do a PDA stent or a VT shunt as an early procedure. TGAs with intact septum, transposition of great arteries, we will operate them within 2 to 3 weeks of age. Transposition of great arteries with VSTs, we operate them within 2 to 3 months of age. Pulmonary atresias, you saw the PDA stenting series, we would like to stent them as early as possible. TAPVCs are an emergency procedure if they're obstructed and they require emergency surgery. And if a TAPVC is not obstructed, we would still prefer to treat them within the first 2 months of age. Now, is there a minimum age or weight for a cardiac surgery? The answer is no. Timing depends on the lesion and the symptoms. And even a 1 kilogram preterm baby can undergo an open heart surgery if it is really indicated. Is there a minimum age or weight for cardiac catheter interventions? And the answer is it's relative. So it's no for a balloon angioplasty because we can put in a balloon in even very small babies, say a 1 kg child can undergo a balloon dilatation of a coarctation or a critical pulmonary or aortic stenosis. But for a device patient, there are some size limitations. PDAs generally, there are now special devices which we can use in preterm infants. Just 2 days back, I put in a PDA device in a 2 kg child who had a PDA with CCF, and the kid had a dramatic recovery and we could discharge the child after 2 days. A VSD device, normally we will wait till they're around 5 to 6 kgs for putting in the device. And for ASD device closures, we sometimes wait till they're around 10 kgs of weight. But these are not absolute numbers. And if required, we can do devices even in smaller children. General recommendations, if a child has Eisenmenger syndrome or a untreated cyanotic heart disease, we tell them to avoid heavy exertion. There are patients who will have severe pulmonary hypertension, history of exercise-induced arrhythmias, dysfunction, cardiomyopathy, or severe left ventricular outflow obstruction or aortic stenosis. And these patients, they should avoid even light exertion. Pregnancy and CHD, if a patient has an untreated cyanotic CHD, Eisenmenger syndrome, post single ventricle palliation with a Fontan operation, severe pulmonary hypertension, severe left ventricular dysfunction, or severe untreated aortic stenosis, pregnancy is contraindicated. But we have many patients who have treated cyanotic heart disease. So say a normal tetralogy patient after treatment, they can have a normal outcome and they can have normal pregnancies. So pediatric cardiac interventions now are pretty standard and we do device closures of ASDs, VSTs, PDAs, even some AP windows. We do balloon pulmonary valvotomies of stenosed pulmonary valves, aortic stenosis, mitral stenosis. We can do balloon angioplasties and stenting of coarctation, and we can put in stents into pulmonary arteries and right ventricular outflows if indicated. And we now also do a lot of neonatal interventions. So critical aortic stenosis can be ballooned, critical coarctation can be ballooned, and we can put in stents into PDAs and RVOTs. I'll end with this very routine case in our cath lab just to show you how we work and what is basically done in cath lab. So this is a patient with a PDA device. So we have an echo machine there to just see the imaging. We need a primary operator, a nurse, a cath lab technician, and an anesthetist. So the first step is the puncture. Generally, we will take both an arterial and a venous puncture. So we use the modified Seldinger technique. And here I'm taking the arterial puncture here. So once our sheath is across the vessel, we will wait for backflow and then put in the guide wires. And then over these guide wires, our sheets will go through which we work. So we are putting in one arterial and one venous sheath here. The next step is delineating the PDA. So we have done aortogram here to see the PDA, and this is the aortogram. You can see that the catheter is, sorry, go back there. The catheter is in the aorta, and this PDA is seen filling here. So this is the PDA, this is the pulmonary artery, and our device has to then sit over here. So the first step after the delineation is to cross the PDA and then to put in the delivery system. So we have crossed the PDA already here, and then over that wire, our delivery system is going in. You can see here that it's going in through the vein, right atrium, right ventricle, pulmonary artery, across the PDA into the descending aorta. Once our delivery system is in, we are now loading the device. So this specific device has 3 discs, and it comes into a loading system here. What is specific and special about devices is that they are made of a material known as nitinol, which has a shape memory. So when we push this device out, they will again reform to take their original shape. So here we are making the system air-free. And then we push the device into the delivery system. And once the device is in, you can see I'm pushing it out of the other end of the delivery system and it's reforming. So this device has 3 discs. The first 2 discs have already been deployed. And this is now the 3rd disc which is deployed. So the device has been deployed here. We are doing angiograms to check that it is in position, that there is no residual flow across the PDA. And once we are happy, we will unscrew this device by turning this delivery cable, and then the device is released. So this is the standard principle of all device closures. That's the end of my talk. I would like to just stress that the prognosis and long-term outcomes of most CHTs is very good, and recent advances in technology and increased operator experience now means that we can do a lot of interventional techniques to treat complex, large congenital heart defects in the cath lab. These are few of our patients. Thank you for your patient hearing.
Thank you, Supratim. That was really an impressive body of work. We are happy to take any questions if at all you have for Dr. Supratim.
Can I ask that question? Hello?
Yeah, we can.
Yeah, please go ahead. Go ahead.
Sir, what is the diameter of the PDA?
So that particular PDA was, I think, around 5 millimeters, and we oversized the device. So that was an 8 millimeter device. But that was a slightly unusual PDA. It was a tubular PDA. Normally, our PDAs are more conical in shape. And so our regular PDA device is the one you saw in the double device case.
The size of the diameter of the guide wire about 1 or 2 mm only?
Yes, guide wires are less than 1 mm, so they're very small. We have different sizes of guide wires. So we basically use coronary guide wires for the very small babies or like the PDA stents, those are coronary guide wires. But if you want to put in a big sheath, we need a 0.035 inch guide wire, which is what you saw was being snared out over which the big sheets were going. So the biggest guide wires are only about 0.035 or 0.038 inches.
Thank you, sir.
Great. Thank you. If there are no further questions, I will thank Dr. Supratim once again. And I shall proceed now to welcoming our next and final speaker for today's meeting. It's Dr. Chintan Vyas. Dr. Chintan Vyas is a senior pediatric hematology oncology consultant with SRCC Hospital. He has an experience of over 10 years in BMT and immunodeficiency, and he's performed over 200 pediatric bone marrow transplants. He has done his fellowship in pediatric hematology and oncology, and his bone marrow transplant fellowship from the NUH Singapore, the GOS Hospital London, and the Imperial College London. So I'd welcome Dr. Chintan to please present his talk and go ahead. Thank you so much.
My slide visible?
Yes, sir, it's visible.
Yes,
I would request others to
can see
please mute it.
Thank you very much, Dr. Zubin, and thanks NH Group to provide me an opportunity to present some of the interesting case, which we may encounter in our common practice, whether it is a general practice or pediatric practice, and how the pediatric cancers, pediatric malignancies are behaving in such a small child. Sometimes we just don't focus on the symptoms. We say that it could be infection, it could be any other symptoms, because we don't suspect cancers in children age group, and we always think that the cancer is a disease of old age group or young. It doesn't happen in children, so that's a little bit different scenario. And we, in a dedicated pediatric setup, we are seeing a lot of referrals. We are seeing a lot of patients who are presenting in such a way that on the initial presentation only we can find out that this patient can have underlying malignancy, and we can refer this patient to a pediatric oncology setup like us. So as we are aware that worldwide approximately 215,000 cancers are diagnosed per year in children. So it's quite a big numbers. It's not like a very rarest of rare disease. And also there are a lot of cancers has been diagnosed in India. Unfortunately, the diagnosis rate of cancer in India is still not, say, more than 30%. Can someone please mute?
I would request the delegates to please mute yourself. We are not able to hear the speaker, please.
Yeah. Sorry. So we are in India. We are still lagging behind the numbers to diagnose the cases, and that's the problem where we are falling short in identifying that red flag signs in diagnosis, early diagnosis of the cancer. Estimated 80,000 cancer-related deaths are happening still in the world, and India in India also we are seeing this type of patients dying with the cancer because of the lack of diagnosis or late diagnosis. Cancer is the 9th most common cause of death in children. So it's really a scary figure that if we compare the death in children, particularly 5 to 14 years of age, cancer is the 9th commonest cause of death. And the reason why the children with cancer succumb is really unfortunate. But the main reason for that is lack of diagnosis or delay in the diagnosis. In today's era, 80 to 85% of the pediatric cancers are completely curable. And curable means we are talking about complete eradication of the cancer from the body, not just a prolonging of life. So if these patients falling prey to the cancer, that means the diagnosis has been sometimes missed and or the delay in the diagnosis has happened. We don't have a very good registries for the cancer, childhood cancer. There are some registries, Delhi-based registries, some Chennai-based registries, particularly, which says that maybe 235 or 150 odd boys or 150 or 80 odd girls are diagnosed with cancer per million. And these are the registries number, but we have number much more than this because a lot of these cancer has not been registered and not been diagnosed. And the reason why they are these registries has come up with the numbers, because as we know in the metros, we have a lot of pollution, we have a lot of carcinogens in the air because of the industrial development and all. So definitely there may be a little bit more incidence of cancer in the metro cities compared to us tier 2 cities or tier 3 cities or villages. And that's how it has been shown in the registries done, particularly Delhi and Chennai based registries. And if we look at the number of cancers, the type of cancers, the commonest cancer is leukemia, which is a blood cancer, and followed by brain tumors, and then followed by lymphomas. So if we suspect, if we draw the pie chart of the childhood cancer, the commonest cancer is leukemia, as you can see, 30%. The second commonest cancer is central nervous system cancer, which is brain tumors, which is 18%. And then the third most common cancer is lymphoma, which is 14%. And the remaining are other solid tumors, which are rare, but still we see this in our day-to-day practice because we're the referral center. And out of the solid tumors, the most two common solid tumors are Wilms tumor and a neuroblastoma. Then other tumors like bone tumors, eye tumor, gonadal tumors like germ cell tumor or soft tissue tumor or muscle tumor is comprising the rarer one or lesser one incidence. So again, in children also, it is not one age for all. The children are different, infants are different, adolescents are different. So as per their age group also, the incidence of various tumors are different in children compared to different in the infants who are less than 1 year of age, compared to different who are more than 15 years of age, like or 12 years of age, who are adolescent, who are teenagers. So if we talk about the children, particularly between 1 to 10 years of age, the blood cancer and CNS tumor, brain tumor is the commonest, following by lymphoma and other rare tumors of solid tumors. But if you compare the tumor which is presenting in the less than 1 year of age, and in that case, I think the commonest still remains the blood cancer. But if you compare only that particular age of less than 1 year, the eye tumor, which is happening in the eye, retinoblastoma, and the neuroblastoma, which is happening in the adrenal gland or sometimes adrenal. These are the tumors which are very rare in general, but they are common in infancy. So if we talk about the percentage in infancy, the neuroblastoma and the other tumors, or sometimes retinoblastoma, sometimes germ cell tumors, brain tumors, these are the common tumors in infancy compared to the children who are more than 1 year of age. Early detection, early confirmation, and early treatment provides the best outcome. So this should be our goal: early detection, early referral, or early confirmation of the diagnosis, and early treatment. Limited spread of malignancy at diagnosis, less toxic chemotherapy or less intensive regimen, good surgery and radiation dose can be combined, and then the patient will have less morbidity and less mortality. But if you have a presentation of a bone tumor or of a muscle tumor who is in stage 4 disease, or if you have a presentation who is a brain tumor who has been not very adequately treated, or same thing for the blood cancers, then the outcomes are not great. So we'll take some of the cases. And would like to highlight the importance of the initial presentation in these cases, because all diagnosis can be done by a good history and examination, and which is very important. And then we lead to a specific investigation and then lead to a specific diagnosis. So this is a case, 4-year-old female, third in birth order, non-consanguineous marriage, who had complained of pain in bilateral limbs, both the limbs, lower limbs, since 1 month, and not walking, not standing. Most of these patients, when they come to us, you see here there is fever which is intermittent, low grade, and some bluish or reddish spots on the legs. But sometimes these don't present with bluish spots or reddish spots always, and they just present with night pains or the pains which is not allowing the child to walk even. Now people feel that could be a vitamin D deficiency, rickets, or all other things, malnutrition or something like that, and they just continue the general pediatric follow-up. And then they sometimes, if there is a infusion, to a rheumatologist, and they do the MRI and nothing significant being found. And these patients continue to have pains. These pains are screaming, like, I mean, they are very excruciating pain, very high intensity pain. People, even the children, even get awake from the deep sleep. They are so bad pains, and these pains are related to something infiltrating the bone marrow. And the signs usually like a fever or low platelet signs, which is reddish patch, which comes maybe later, may not be early in the diagnosis. These patients usually get treated if the patient is having fever with low platelets. They ignore the limb pains, they ignore the general examination, and sometimes been treated with the commonest infection like dengue and malaria or typhoid. So what sometimes, if there is an joint effusion, they reach to a rheumatologist or orthopedic doctors, and we do the MRI, and then we find out there is pain and rash and fever. And these patients unfortunately been started on steroids. So if they are started on steroids, considering that this could be a limited joint problem or a bone problem, then we are in a trouble. And the reason why we are in a trouble, because the steroid is a double-edged sword. It does help with the symptoms. The pain will go, the fever will go, rashes may or may not go, but it will lead us to a delay in the diagnosis. And then after a month or two, when the pain is not subsided, the effusion is not subsided, the fever is not subsided, initially subsided, then came back again, and then the patient sees the actual CBC report, and then we found that there's something wrong in the CBC report. So that's the very important. Now, if this patient has presented to us, and if we simply miss the general examination, which is very common in our practice to do a good general examination, we sometimes miss this problem. Let us say if we ignore the lymphadenopathy in this patient, or if we ignore the organomegaly in this patient, then probably we are not focusing on the right system, and then sometimes this diagnosis been delayed. So if we have these type of presentation with the lymphadenopathy and with the hepatomegaly, sometimes splenomegaly, sometimes may not be there, and if we think that what could be a differential diagnosis, so in this case, yes, infection still remains the common differential diagnosis, but there has to be something more, and that something more will give us a clue from the simple complete blood count. Now, this is a very simple CBC, and I have deliberately highlighted the two things only, which only we look at. We look at the hemoglobin, we look at the platelet, and we ignore the rest, because we say the white cell counts are 6,500, which is normal. Hemoglobin is low, platelets are low. Maybe this patient is suffering from dengue or malaria or any other typhoid-like infection. We just treat with antibiotics. We ignore sometimes hepatomegaly. We think it could be infection related. We ignore sometimes lymphadenopathy. We think it could be infection related. But if we look at the differential count of this patient, who is 4 years of age, and if we found the neutrophil, which is polymorphonuclear lymphocyte, polymorphonuclear cells, these are only 16%. You cannot have the 16% neutrophil in a normal child, or let us say even in an infected child, with the 74% of lymphocytes. Some lymphocytes are still there because of reaction to infection, but 75% lymphocyte means it is occupying a lot of your white cell count, and this may not be the normal lymphocyte, and we have to look under the microscope that what type of lymphocytes are this. we simply do the uric acid and LDH test, because these are the tests which will give us the diagnosis sometimes that whether this low hemoglobin and platelet with the lymphocytosis is something related with the malignancy or not. And if you find the high LDH and uric acid, probably you may suspect something high turnover, something high metabolism is going on in the body, and which can lead us that maybe these lymphocytes are not normal lymphocytes, and this may be something different. Even a good radiologist like Hiren will tell us that, oh, there are some metaphyseal lines being seen on the X-ray of the lower limbs, and please rule out leukemia. So we have seen that type of reports where even in the X-ray metaphyseal lines with this type of clinical suspicion of leukemia or a malignancy in the blood, we can suspect that this is something, not just a simple infection. We do the bone marrow, and we found that these are all the lymphocytes, and these are not the normal lymphocytes, these are the blasts. So these are the abnormal lymphocyte, and this patient is not suffering from any dengue, malaria, or typhoid-like illness, or not suffering from any juvenile rheumatoid arthritis-like illness. This patient is suffering from an acute lymphoblastic leukemia, which is one of the commonest malignancy in pediatric age group. And the only way to diagnose, to early pick up this patient, is to look at the lymphocyte polymorph ratio. If the lymphocyte polymorph ratio is reversed, or if it is lymphocyte predominant with the bicytopenia, with low hemoglobin and low platelet, with organomegaly and lymphadenopathy, with bone pains, I think we should always think of a hematological malignancy. Now, this is a prototype case 1, where we would like to highlight the importance of white cell count and differential. Now, let us come to the case number 2. So the case number 2 is a 9-year-old male child, second in birth order, and this patient is presenting to us with a chest pain of 1.5 months with productive cough without hemoptysis for 1.5 months, and fever for 10 days and respiratory distress for 2 days. Now, this is a very classic picture of tuberculosis, and we found in India the tuberculosis is one of the commonest infection with fever, cough, weight loss. But there is no history of weight loss in this particular patient. There is no history of any night sweat, loss of appetite, or any COX contact, or any trauma to chest. For some complaint, the patient consulted 1 month back. So this was just a broad history. And here there is no COX contact or no history of tuberculosis in the family or in the past history of tuberculosis in the patient. We do the simple chest X-ray. We have done the CBC. The CBC looks more or less normal. The white cell counts are slightly higher, but it is fine. 10,900 is not that high. Polymorph is 60%, lymphocyte is 20%. So the ratio is maintained. Platelets are normal. ESR is 5. So again, rule out any chronic infection. And there is a pleural effusion. Now, significant pleural effusion, significant opacification of the lungs, and with even the deviation of the trachea. Now, this X-ray is very important, and this X-ray could be simple infection X-ray, or maybe something else like a TB or what. But when we do the pleural tap and we find that nothing is there, there's some cobweb present, but nothing significant is there in terms of the pleural tapping. And but still we feel that the TB is the commonest diagnosis. The presentation is a common X-ray unilateral opacification. This still could be a tuberculosis because we have blood counts normal. So in the first case, I have highlighted the importance of CBC. Here, I'm saying that CBC is normal, does not rule out the malignancy. Now, this patient was started on antituberculous treatment, improved after 10 to 14 days, but there is a recurrence of fever and respiratory distress. Now, how to proceed? This patient is having tuberculosis alone, or is there something else? So a good clinician would always correlate the the X-ray chest with the CT chest. And the reason why I am saying that to do the CT chest, because CT chest will delineate a lot of structures, will give us the lymph node evaluation, will give us the evaluation for a mediastinal mass, will give us any structure or any other lung abnormalities also. So that is very important to do the CT chest in the right time, in the right patient. All infection with hemoptysis may not be the tuberculosis. Now this patient has undergone the CT chest, and we can see this huge mass. and there was some mediastinal lymph node and lymph nodes also. And then we found this patient has a very high LDH, 5,400. Normal LDH is less than 300. Now this patient is having very high LDH and very high uric acid. The uric acid is also 12.8, which is significantly high. So again, in the previous case also, I have highlighted the importance of LDH and uric acid. Here also LDH and uric acid is high. So if you have an LDH and uric acid is high, that means your body is having a lot of high turnover, a lot of high metabolic activity, and this can come from cells which are rapidly proliferating, and the rapidly proliferating cells should not be anything else than the cancer. Again, the white cell count, hemoglobin platelet may not be that abnormal in these type of patients. Polymorph lymphocyte ratio is maintained, but these patients need a lymph node, the CT guided biopsy, and then we can confirm that what this tumor, what this opacification of the lung was not just a simple infection, and we found that the patient had a malignant round cell tumor. So round cell tumor is a type of lymphoma. The lymphoma cells look round and blue under the microscope, so that's why they are called round cell tumors. They are also called small blue round cell tumors. There are other differential diagnoses also of small blue round cell tumors, and this patient was diagnosed with the help of immunohistochemistry and flow cytometry, a lymphoblastic lymphoma. Then we do the staging workup, we do the PET scan, and we found the patient had a limited disease, and we started the patient on very simple drug called dexamethasone, methylprednisolone, and the patient responds beautifully within just 7 days of steroids. And then that steroid is not the end of the game. We have to continue the patient on a chemotherapy, a full course of chemotherapy, and then the patient remains in remission. So this is a kind of very important message that all the respiratory distress and chest infection may not be a tuberculosis or bacterial infection. The pleural tap sometimes may miss the diagnosis, and the CT scan at the right time with the biopsy of the mass or whatever the nodes are there is very important to rule out a lymphoma-like illness. Now, when we look at the CT chest, again, there may be some students or for general pediatrician purpose, we have to divide the mediastinum into 3 categories: anterior mediastinum, middle mediastinum, and posterior mediastinum. And if we see that the commoner enlargement in the anterior mediastinum is thymoma, teratoma, seminoma, or lymphoma. In the middle mediastinum, it is lymphoma predominantly. And in the posterior mediastinum, there are neurogenic tumor like a neuroblastoma. Now, these are the common malignancies. Then there's some uncommon malignancies, or let's say benign tumors like lipoma, lymphangioma, aortic aneurysm, which can be seen in anterior mediastinum, bronchogenic cyst, metastatic cyst, or systemic granuloma in the middle, and the xanthogranuloma or diaphragmatic hernia in the posterior mediastinum. So we have to think based on the CT scan report, whether it is anterior mediastinal, medial mediastinal, posterior mediastinal, and based on the clinical diagnosis, we can categorize this patient, whether this patient could be a thymoma or lymphoma, or this patient could be a neuroblastoma, or this patient could be a germ cell tumor. So there was a case 2. Now come to the case 3. Again, a very common presentation. 14-year-old female, persistent lymphadenopathy, lymph node swelling on the neck for 1 month, and a fever for 2 days. Family history of Cox TB present, weight loss present, occasional cough is there. And on examination, there was a pallor with multiple matted lymph node, and in the right cervical region, largest measuring 2 by 2 centimeter, non-tender. Spleen is just palpable, liver not palpable, and the rest examination is normal. So again, the case very simple, very common presentation, which we see in our day-to-day practice. Again, we think that could be a tuberculosis or some infection. So the routine CBC, again, the CBC is normal here. The hemoglobin normal, platelets normal, neutrophil lymphocytes ratio is maintained. But ESR is 79, CRP is 6, Montux is negative, and chest X-ray is normal. And the commonest way to approach this type of patient is to do a FNAC of lymph node, and which is commonly done in the pediatric population, even in the adolescent and adult population. And 70-80% of the time, it just mentioned reactive lymphadenitis. We do the gram staining AFP, it comes normal, and the patient receives that, oh, this is nothing, just a reactive lymphadenitis, maybe TB, may not be TB. Let's give a trial of amoxicillin for 14 days. and then the size of the lymph nodes starts some sort of reduction. So temporary reduction has happened, but the fever and weight loss is persistent. Now, there the clue is that should a simple FNSE will rule out the malignancy, or should there be something else? Now, or should this patient with a trial of augmentin or anti-TB treatment getting better, is this the end of the story, or there's something else? So in such scenario, in ideal way, if we want to rule out any non-infective cause, we have to do the lymph node biopsy. And the lymph node biopsy should be excisional lymph node biopsy. It should not be FNSE only. And once we do the excisional lymph node biopsy, and if we send the patient, send the biopsy to histopathology, then we can know that what is exactly the patient is suffering from. And if we can see this slide under the microscope, it is a very classical all eye appearance, or we can say the binucleated or mirror-like cells. You can see these cells mirroring each other, and a lot of a big cell. So this is nothing but cells which represents the Hodgkin lymphoma. So this is called, the cell is called the Riestenberg cells, and this is very classically seen in Hodgkin's lymphoma. So again, the clue is that lymph node biopsy should be done to identify the patient, whether this is suffering from the malignancy or not, and CT chest and further staging workup can be done, and the correct diagnosis can be made. These patients sometimes do present to us with 2 months or 3 months of lag because they have been treated with anti-tuberculosis treatment or antibiotic. Simple lymph node aspiration was always normal, so they think that this is not a malignancy. And these patients are not acutely sick patients. They don't fall sick. They don't have too much of fever. They just have a small low-grade fever, little bit of weight loss. But night sweats are something very common in these patients. And if the lymph node biopsy is done, then this patient can be diagnosed early. If the lymph node biopsy has been delayed, and if the presentation is 3 months or 4 months down the line, we see a metastatic Hodgkin's, and that means that the simple limited Hodgkin's, which would be a stage 1 or stage 2 Hodgkin's lymphoma, when they present to us after 3 months or 4 months, they present as a metastatic Hodgkin's, stage 4 Hodgkin's, so which requires radiation and all. So that's the importance of the early diagnosis in these patients. So the classical Hodgkin's lymphoma is CD30 and CD15 positive, and the staging workup can be done by bone marrow aspiration biopsy and the PET scan. And the chemotherapy is the main backbone of the Hodgkin's lymphoma, and some patients do require radiation followed by chemotherapy. Then there's a case 4. So this patient is a 4-year-old patient, male child. This patient has presented to us with one episode of hematuria without any burning, micturition, or fever. There was no history of medication, no history of trauma, or no history of surgery. The vital examination is normal, except the blood pressure is 138/90. So the blood pressure evaluation in a patient who is suffering from hematuria is very important. And we ignore sometimes blood pressure measurement, particularly who are tuned to see the adults, because we see that the 120/80 blood pressure is normal for adults, or 130 or 140 blood pressure is normal for adults. But when we deal the pediatric patients with the blood pressure of 138/90, it is significantly high. If we don't check the blood pressure, we don't know what is the blood pressure. So importance is to check the blood pressure. Importance is that the hematuria, whether this hematuria is associated with any UTI like of symptoms or not, whether this hematuria is associated with fever or burning micturition or not. And then complete systemic examination as well as general examination is very important. And the examination, why it is important? Because these patients sometimes do give us a clue if they have any dysmorphic faces or any genitourinary abnormality. And then we can diagnose, pinpoint those patients, that these patients are not only simple UTI, these patients are suffering from something else with just a general examination. Sometimes these patients present with incidental abdominal mass, and the incidental abdominal mass is very important to see that what are we suffering from. That incidental abdominal mass sometimes being very much ignored, but sometimes it is very easily picked up by even a caretaker or a mother or father, who just see that while feeding the baby or while touching the abdomen there is some mass field, and then they land up with a pediatrician, and then they do the ultrasound, and then we found some mass in the kidney. That is also a one very milder way of presentation. So in this patient, we evaluated with the routine blood test, CBC, kidney function test, urine routine examination, urine culture, and everything came back more or less normal except the microscopic hematuria. Ultrasound abdomen was done finally, and it was showing 5 by 5 centimeter, a defined lobulated mass. Now, what next? What this mass could be, whether we need to do biopsy of this mass, whether we need to do CT scan of the abdomen. So those are the questions. So the first and foremost is always a CT scan of the abdomen. And when we do the CT scan of the abdomen, we see that there are many benefit of doing CT scan of the abdomen, which is very simple. And the main benefit is to find the organ of origin, because ultrasound kidney mass sometimes may be a kidney, sometimes may be a suprarenal mass, adrenal mass. In the CT scan, we can exactly identify the organ of origin. We can also identify the other kidney or other organ which is affected. We can also find out the extension of the disease, whether this disease is limited only to a kidney or it is spreading beyond the capsule of kidney, it is spreading, involving the lymph nodes, whether it is involving any other vital structures in the vicinity of viscera in the abdomen. So we can see the bones, we can see the lymph nodes, and we can see the vascularity of the tumor, or we can see how the heterogeneous the tumor is, whether there is any calcification in the tumor. These are all the findings which we can see in the CT scan. And particularly this tumor, which may be a Wilms tumor. These tumors sometimes are localized tumors, sometimes they breach the capsule and go to the other side, sometimes they involve the other kidneys. But if we see a different type of tumor similarly presenting in the abdomen with abdominal mass and neuroblastoma tumor, they are very extensive and they usually cross the midline. They usually surround or encase the big vessels. They sometimes infiltrate the big vessels, and they are very different in terms of the treatment compared to Wilms tumor. So the organ of origin, extension of tumor, whether they are surrounding, whether they are infiltrating the vessels is very important, whether there is any calcification. Sometimes we see the tumor like hepatoblastoma also, which is again a huge tumor arising from the right side of the abdomen, liver, and so huge that it occupies almost half of the abdomen. So these are the common abdominal mass which we see presenting as a malignancy in pediatric population. Now, these were the syndromes which I was talking about, that when you do the general physical examination, you rule out any dysmorphic faces, you rule out aniridia, you rule out ectopic pinna, you rule out hemihypertrophy of the limbs, you rule out short stretcher. This is a picture of aniridia, genitourinary abnormality and all. So all these, the general physical examination, the syndromic features will give us the clue whether this patient is only suffering from a simple UTI or there is something else like a syndromes or something going on in the body. Now, when we look at the abdominal mass in the children or in the older children, the commonest is renal. 55% is renal, out of which 25% is Wilms. Then the remaining are the non-malignant cause like hydronephrosis, cystic disease. Non-renal retroperitoneal mass like neuroblastoma, which I was discussing before, is 21%. Teratoma is, and others are 1%. There may be a gastrointestinal mass like appendix or lymphoma, particularly in the presenting like an intussusception or a mesenteric lymphadenopathy. Hepatobiliary mass like a hepatoblastoma, which we see in our infant particularly, and genitourinary mass like ovarian cyst and teratoma, which can be seen in the infancy and which can also be seen in the adolescent age group. When we talk about the neonatal mass, the differential diagnosis are slightly different. There, the non-malignant mass predominant over the malignant mass. And if we talk about the hydronephrosis or cystic disease of the kidney, these are the commonest non-malignant mass. The malignancies are like nephroblastoma, blastomatosis, or mesonephric nephroma. in the pelvic region. Teratoma and ovarian cyst is quite common, particularly in the infancy, in less than 1 year of age. It can present even at the neonatal age. Non-renal adrenal mass like neuroblastoma, again 10%, and then some benign GI mass like duplication or cyst, and then hepatic tumors like hepatoblastoma. So these are the various differential diagnosis of abdominal mass in the children, and then abdominal mass in the neonatal age group. Now let's come to the case 5. So this is a case of 11-year-old who is presenting with vomiting and early morning headache. Now this is again a very common feature presenting in adolescents, and they may be very commonly linked with migraine, or sometimes linked with the schooling also. They sometimes may be functional also. But the difference between headache in the adolescent comparing with a migraine or comparing with a functional headache, the early morning headache is something which is very red flag, very significant and very important to look at. Early morning headache with vomiting is a very important sign which we need to worry, in particular this type of presentation. These patients usually receive antiemetic, paracetamol, but vomiting settles, but mother still worries as he has vomiting at least once in the morning, and well for the rest of the day. So early morning headache and vomiting is there. In the daytime, the patient remains well, persistent complaint for 3 weeks, no hard neurological signs, and again, some of this headache could be linked with refractory errors. Patient do check up with refractory error, and then the ophthalmologist will say, okay, there's nothing much to worry. Maybe there may be some refractory error, and the vomiting could be non-significant, and this patient again just gets delay in the diagnosis. Now, when we see that there is early morning headache and vomiting, and the ophthalmologist sometimes tells us beyond a refractory error and tells us that, look, there is some fundus abnormality, there is some pallor in the fundus, there is some papilloedema in the fundus, there is a loss of optic disc demarcation, and this patient warrants something more than just a plain and simple ophthalmological evaluation. So then this patient is very important in terms of the evaluation, because the MRI scan is very important, and urgent MRI scan needs to be done. This papilloedema should not be ignored. Now, when the MRI is done, you can see this MRI. You can see that there is some tumor or some mass sitting in the posterior fossa of the brain. Now, when this posterior fossa mass is being seen, that could be a malignant, that could be a non-malignant mass, but majority of this posterior fossa mass in our population, they are malignant. They are not like a meningioma which has been seen in adults or non-malignant mass, but these are usually a very common pediatric brain tumors which present in the posterior fossa of the brain. So what this could be, this is again an MRI finding. You can see a classical posterior fossa tumor which is localizing in the cerebellum. This could be in the cerebellum, this could be involving the third or fourth ventricle, extending into third or fourth ventricle. This can extend down into the spine also. So these are the classical posterior fossa tumor. So when we see this type of MRI picture, sometimes we can pinpoint that what could be the differential diagnosis, whether it could be a medulloblastoma, whether it could be some other posterior fossa tumor. But sometimes it is difficult to just classically tell on the MRI, and we have to undergo a surgery. And once the surgery is done, the biopsy report will tell us that whether it is a medulloblastoma or something else. So, but important thing is that the MRI needs to be done to see what is the location of the tumor and what is again the structure of the tumor looking in the MRI, whether there is any heterogeneity, whether there is any other features which is causing obstruction in the ventricles, or any other features like ventriculomegaly, hydrocephalus and all. So the red flag signs in the brain tumor is persistent vomiting on awakening, persistent headache on awakening, change in behavior or school performance, persistent visual problems, growth failures associated with delay or early puberty, precocious puberty or delayed puberty with polyuria, polydipsia, means they are associated with supratentorial or infratentorial region where they are affecting the pituitary gland and this presenting with the hypopituitarism, or sometimes they are affecting, they are causing a precocious puberty and increasing in head size in the young children like infants, and atypical or focal seizures. So these are the common red flag signs which we need to worry, in particular in the case where we are thinking that whether we are missing a brain tumor in a children, because again I'm saying that to suspect a malignancy in children requires a lot of experience and requires a lot of pinpoint red flags to be told to a general pediatrician or a general practitioner that look, this early morning headache may not be a normal and it cannot be ignored with a migraine. So this is a very important message which I would like to give, that these are the red flag signs which we need to worry and we need to evaluate with simple investigation, physical examination, and MRI definitely is required. Then another case, which is 16-year-old male child, a football player, presented with 2-month history of right lower thigh and knee pain. So this is very common in adolescents, where they usually play games, football, basketball, and they get hit by the local trauma, and sometimes they get hit by the colleague, by their friends and all that. Then usually what happens that they usually have a trauma, they usually have a swelling, and then if their trauma and swelling is not been evaluated properly, they usually continue to have that swelling and pain. They usually consult the orthopedic doctors, and MRI has been done. There may be some swelling, but no confirmed diagnosis has been made. The swelling and pain gets worse with the activity, and there is no weight loss, fever, or joint diffusion. So again, we think that whether it is simply related to trauma or is that something else. Again, very difficult to differentiate on the basis of history, because yes, there is a history of trauma, there is a history of swelling, pain, and tenderness, which could be simply related to the trauma. But when this patient been evaluated with orthopedic surgeons, been taken care, but a good orthopedic surgeon will always look at the MRI and will always see that whether there is any abnormality. Even it can be simply done with a simple X-ray also. But when we do the MRI, we can see that whether there is simple bone effusion or bone erosion, or whether there is any mass sitting in the bone. There may be very small mass, there may be just a simple erosion of the periosteum of the bone in the beginning phase, which may be initially missed by the MRI. But when it reaches to a tumor, very big tumor, it usually it's seen as a big mass. And then this is a tumor where we can think that the early intervention is very important. This is the osteosarcoma kind of tumor, and the reason why I'm saying osteosarcoma, because it is localized in the metaphyseal region. So this is a very classical site of the osteosarcoma. The similar common bone tumor in our pediatric population is Ewing sarcoma, and these all tumors usually present in the adolescents. They present with a classical history. They are tall athletes. They present with some trauma. The trauma being ignored with that injury, with the swelling. MRI also been done, but not much done. Evaluation done further on the MRI, and then they present to us with a huge swelling of the limb, in eroding the skin also of the joint and limb, and then we do the evaluation and we found the metastatic tumor. Now this, which could be a localized tumor, if they land up after 3 months or 4 months, that tumor usually spreads in the lung or in the other bones. And if they spread into the other bones, it is called a metastatic tumor. So then the outcome usually is quite worse compared to the patient who are having localized tumor. So if we suspect the bone lesions, the common bone lesions are osteosarcoma and Ewing sarcoma. And if we think the benign bone lesions like osteodosteoma, osteoblastoma, and chondroma, these are the benign or non-neoplastic lesions like fibrous dysplasia, fibrocortical defect, aneurysmal bone defect. Sometimes the rare disease like Langerhans cell histiocytosis or giant cell tumor can also present in this way. So again, the message here should be very important, that the bone trauma is just an inciting or just a coincidental finding. This has nothing to do with the trauma. It is not that the trauma has caused the tumor to develop. It is just an incidental trauma. This patient's bone has to have a tendency to develop the tumor, and this is just a falling after the trauma episode. So not all the trauma are tumors, but yes, if we have an MRI evaluation done, and if you look at carefully, even in the simple X-ray, which I can show you. Sorry, not done here, but this, even if the simple X-ray can tell you whether there is something wrong or not. If we look at the periosteal elevation on the shaft of the femur or radius or ulna, if you see there is any periosteal elevation, which we call the onion peel appearance, or a sun ray appearance, particularly sun ray appearance is seen in the giant cell. This osteosarcoma, the onion peel appearance is seen in Ewing sarcoma. The metaphyseal site is classical of osteosarcoma. The diphyseal site is classical of Ewing sarcoma. So even the simple X-ray with osteolytic or osteoblastic lesions can give us the diagnosis, can give us the clue whether which type of tumor is there, whether it is Ewing sarcoma or osteosarcoma. Ewing sarcoma usually have an osteolytic lesions. Same thing for Langerhans cell histiocytosis. They will have usually an osteolytic lesions compared to the other tumors like osteosarcoma. Or in adults, we see the bone metastasis like prostatic cancer or breast cancer. They present with a bony metastasis, and those metastases are osteoblastic, means they have a dark density compared to the osteolytic, which have a lucency. And there we can differentiate one tumor versus other tumor on just basis of simple X-ray. The last case I would like to discuss is a very young infant present to us on a physical examination. We see that everything is normal, happy child, but sometimes on the general examination we miss, but sometimes on the detailed examination we see that there's a leukocoria in the eye. In this particular case, sometimes we miss, we are not able to see in this phase whether this light reflex is there or not. This phase is classical, but this phase we sometimes miss, and we say there's maybe a little squint in this child. We refer to the eye doctor. We say mother notice that it's a lazy eye, and then we do the ophthalmic evaluation and we see what kind of problem this patient could have. So this is a very classical leukocoria, a white pupil, which we see in infants. And when we see the white pupil, it should always raise the alarm. And the commonest eye tumor, retinoblastoma, is the one which is seen with a white pupil or leukocoria. Other differential diagnoses are congenital cataracts, congenital uvula, keratitis, congenital glaucoma, congenital corneal opicities, torch group of infection. So all these are the common differential diagnosis. But when you see the light leukocoria or white pupil, you should always suspect a tumor which is sitting in the eye, in the retina, and is called retinoblastoma. So again, the physical examination on infancy, any abnormality in the eye has to be dealt with very carefully. These tumors are very familiar, having very familiar tendency, and sometimes you have to look at the other children. You have to ask the history of family, and we can find out any we can correlate any family history, because these are autosomal dominant tumors, and we can counsel the parents accordingly. Genetic counseling can be done, particularly if we establish this type of diagnosis. So I would just end by saying my few take-home messages, that bone pains without arthritis, which are asymmetric bone pains, which are not very classical in general, like a rheumatoid arthritis, we should suspect. And particularly if there is any pallor, hepatosplenomegaly, or lymphadenopathy, we should suspect hematological malignancy in the bone pains patient. Peripheral smear with bone marrow aspirate or refined bone marrow biopsy should give the answer, but important answer should come from the CBC, and particularly neutrophil count, platelet count is very important. Neutrophil lymphocyte ratio is very important. pallor with bone pains and does not always say it could be a bony tumor or bony problem. It could be a simple hematological problem, and which this bone pains are because of the marrow infiltration. LDH is a high index of suspicion, which can tell you that the body is producing a lot of cells. These cells are undergoing a lot of metabolism, replication, and this suggests a high cell turnover. And so simple LDH and uric acid uric acid evaluation can tell you whether this is not a routine problem. This could be something related with a high metabolic turnover. Not all pleural effusions are tuberculosis. And when the TAP is done, we should search for all the etiology and not just the infection. So that is very important message which we would like to give. Steroids to be used very judiciously. If we use steroids, we mask the leukemia. We sometimes, even with a couple of days of steroid, the all blast in the peripheral blood disappear, and then the patient becomes completely well, fever goes, pain goes, but after 5 days or 7 days or 2 weeks, again the thrombocytopenia starts happening, the anemia starts happening, and the patient present to us in a partially treated form. We also use steroids, but we use steroids with the chemotherapy, and that's the important message, that steroids should not be used if we have any doubt in the peripheral blood examination, CBC examination, that this patient could be a leukemia patient. Steroid has to be used only after doing the bone marrow examination and ruling out leukemia, particularly when we have a high index of suspicion. In patient of hematuria, always check the blood pressure, and we should rule out abdominal mass in those patients. Do ultrasound and CT scan later on. Careful examination of kidney should be done. Even if examination is normal, USG should be done, because sometimes we don't feel the mass, but in the ultrasound there may be a small mass sitting in the kidney, which may not be palpable always, and particularly with the hematuria and hypertension. So with cancer on rise, pediatricians play an important role as frontline physicians to suspect and refer early, and a still major role in a shared continuing care of the child. This is what my message for today, and we can see all these our childhood cancer survivors sitting with another cancer survivor, and we can see once we treat these patients adequately in the right time, right place, right way of the treatment, with early diagnosis, all these patients are survivors. These are not a normal children. These are all the patients who had undergone chemotherapy, fought with the cancer, survived, and then presented to us in a childhood cancer survivor meet. They have normal hairs, normal growth, and normal face. So nobody can identify this. These patients would have had the cancer at the early age of life. And this is the message, that pediatric cancers are difficult to diagnose sometimes, but if they are diagnosed in the time, treated in the timely manner, in the right way, in the correct setup, and with a strict follow-up, these patients can be a normal survivors, and these patients are really do whatever they want to do in their life. So that's my message, and I would stop here and would take any questions.
Yeah, thank you, Dr. Chintan, for such a nice talk. The main highlights that you choose a case from different systems and scenarios, and you try to give some sort of teaching points which we should applicate in our routine regular practice. That was wonderful. You specifically mentioned about the use of steroid, when to use, when not. That was very important, because we all are afraid when to use, and we sometimes overuse it and then mask the underlying disease abnormality. You also mentioned when we should do imaging and those kind of thing, and what will be the imaging modality of choice. So in that way, it was very good. Your last photo is also very encouraging. And thank you for taking such a wonderful talk. And if the delegates have any questions, they can directly ask to Dr. Chintan. Anybody has any question? I guess there are no questions. So that brings us to the end of today's session. And I hope everybody would have enjoyed and learned through our eminent speakers in all different subspecialties. And our next program also, we have identified the topics and the speakers. I would like to share you that findings. So basically, our next webinar will include topics on the one. Yeah, so the tentative topics would be evaluation of the lump in abdomen in children by Dr. Rasik Shah, who is our senior pediatric surgeon. And followed by, we have another one hemato-oncologist, Dr. Shweta Bansal, who will be talking about the management of the Wilms tumor and neuroblastoma. And followed by, we have got one opthel topic, which will be taken by our senior eye surgeon, Dr. Himika Gupta. She will be speaking on the common eye problems and its management. So we'll circulate that flyer also soon. And thank you very much for attending all the delegates. I can see the appreciative comments in the chat box. Thank you for that. And we will continue doing so with different eminent speakers and different topics, which can be useful for all general pediatricians and even the GPs, the general practitioners. And by that, see you next time. Thank you for attending.
Thank you, Hiren. Thank you very much.
Yeah.